Good morning, good afternoon, good evening, bonjour, buenos dias, bienvenue. Welcome to all of you from wherever you may be joining us from around the world to this World Health Professional Alliance webinar on bridging global health agendas, NCDs, AMR and interprofessional collaboration. My name's Howard Catton. I'm the CEO of ICN. I'm a nurse and I'm your moderator for this webinar. And you can see that we have a fabulous lineup of speakers for today as well. This event is part of the World Antimicrobial Awareness Week that runs from the 18th to 24th. We're aware some of you will be joining us from parts of the world where English isn't your native language. Translation is available, and you can see on the screen here your instructions to access translation. Turn on the captions, enable the translation toggle, choose your preferred language, and then you'll be able to follow along with live translated captions. I'll leave that for just another 10 seconds to make sure everybody who needs it is able to access the translation service. As I said, this is part of World Antimicrobial Awareness Week. And many of you, I'm sure, will know that antimicrobial resistance is one of the top 10 threats to global health identified by the World Health Organization. Estimated that it could cause up to 10 million deaths by 2050. But we need to take a cross-sector and a cross-border approach, One Health approach, not just health, but animal welfare and well-being and the environment as well. And therefore, for this World Health Professional Alliance webinar, cross-professional collaboration is clearly critical to addressing a cross-sectoral and a cross-border issue. On to the next slide, please. For those of you who don't know, I hope that's very few of you, but the World Health Professions Alliance is the alliance of the organizations that represent the health professions internationally. The World Dental Federation, Federation for International Pharmaceutical Professionals, the World Medical Association, World Physiotherapy, and the International Council of Nurses. We estimate that there are in the region of 47 million health professionals around the world and represented by our organizations. Current global estimates would put the total healthcare workforce between 65 and 70 million. So health professionals represent around about 2/3 of the entire global healthcare workforce. Our organizations cover 179 countries and territories, have 735 national member organizations. And within our strategy, our objectives and our mission is to support the strengthening of healthcare systems through interprofessional collaboration and through partnership working as well. Next slide, please. We do this in a number of ways. Here are some pictures. The picture with lots of people in it that you can see are the presidents and CEOs of the members of WHPA, and this was on the occasion. You can see there, just if you look hard, you can see Dr. Tedros. This was when we signed a memorandum of understanding with WHO in 2020. We work very closely with the World Health Organization. We always have events at the World Health Assembly. There's a picture of one of our a couple of our side events, and we focus on issues that may relate to healthcare workforce shortage, issues of migration, non-communicable diseases, vaccinations, climate change as well, of course. And we also have the opportunity to speak, to make interventions at WHO meetings, at their executive board meetings, and at the World Health Assembly as well. Next slide, please. As I said, collaborative working, we believe, is absolutely so critical and important. We all know that, great healthcare is the result of great team working. And we're committed as international organizations to try and demonstrate that in the way that we work together. We have regular meetings and sharing of information. We provide peer-to-peer support. We provide joint policy statements and evidence campaigns on a range of issues, including working conditions, positive practice environments as well. And we support connections and partnerships with other organizations. And just most recently, we've been collaborating in relation to, for example, the COP climate taking place in Brazil, in Belém. On the WHA website, you can find many more details of each of the organizations, links to the individual organization websites. You can access the policy tools, evidence, and some of the resources that I've mentioned as well. Please do get in contact and connect. We'd love to hear from you. Next slide, please. The webinar, so everyone knows, is being recorded and live streamed via YouTube. So it will be available after the meeting on the FIP website. Our colleagues from FIP are very kindly providing technical support for this webinar today. Thank you, FIP. You can ask questions through the question box. We're going to be monitoring those. I can't promise we'll get to every question, but we will be answering as many as we possibly can. And of course, you're welcome to provide feedback and register for other events through the links that have been provided. So without further ado, let's move on to the first, next slide, please, of the speakers that we have for you today. Just so that you know, each speaker is going to speak for about five minutes, and then we'll have an opportunity to react to what each of our speakers have said. And then at the end, after we've heard from everybody, we'll have a more general question and answer session. Our first speaker is Dr. Wendy Thompson. She is an academic dentist working in the northwest of England. She's a clinical senior lecturer in primary dental care at the University of Manchester. She works part-time as a GDP as well. And she's a lead member of the World Dental Federation's award-winning antimicrobial program that I believe was presented at the UN General Assembly recently as well. Wendy Thompson isn't with us in real time today, but we have a video from her with her intervention. So without further ado, please do play Wendy's video.
Hello, my name is Dr. Wendy Thompson. I'm chair of FDI's Preventing AMR Infections Task Team, and I'm a clinical senior lecturer in primary dental care at the University of Manchester. Today I'm going to talk to you about AMR and oral health. So FDI, World Dental Federation, represents more than 1 million dentists worldwide, across 191 member associations and 134 countries. We're about knowledge exchange, advocacy, and innovation. Poor oral health can be life-threatening. People don't think about it, but it can be. You can see in these 3 pictures here, the first picture has someone with periorbital cellulitis. That is very close to the brain, and the infection there can track back, cause brain abscesses, which is, it's not a happy outcome for the patient after that. I'm talking life-threatening and life-ending. The middle picture is someone with something called Ludwig's angina, which you can see the infection there is in the floor of the mouth and spreading into the neck. And again, that's some vital structures there and closing off the airway. And there's a lot of important blood supply in that area. And so sepsis is a near and present danger. So all of these conditions can be life-threatening unless they receive the right treatment. In these cases, these dental infections do need antibiotics that are going to work, but they also need the infection clearing, removing the source of the infection. Oral and dental disease is the most common non-communicable disease globally. At the United Nations General Assembly earlier this year, the high-level meeting on NCDs included a side meeting on AMR, and I was really proud to talk about AMR and oral health as part of that meeting. Antibiotics for dental infections are not normally necessary. The pictures I showed you earlier are when it's got to an extreme where they're vital, but actually a very high percentage of dental infections can be cleared without antibiotics. The WHO Aware antibiotic book identifies 4 infections that might be appropriate. They're not always appropriate, but might be appropriate for antibiotics. That's a dental abscess, pericoronitis, that's when people have got wisdom teeth problems, necrotizing periodontal disease, that's to do with gum disease, where the gum is being eaten away by a combination of the host immune mechanism and reacting to the bacterial load. And NOMA, which is a neglected tropical disease. It starts as necrotizing periodontal disease and then moves on, and it kills a very high percentage of children who get it. It's known as the face of malnutrition. It kills because it eats away the soft and the hard tissues of the face, and within 2 weeks, unless without effective antibiotics and without effective nutrition, these children die. All of these oral and dental infections or conditions that I've talked about are non-communicable diseases. Most of them are completely preventable, and they're usually treatable without antibiotics. They're non-communicable, that means not infectious. And yet in the Global Action Plan on AMR, Strategic Objective 3, it talks about reducing the burden of infectious diseases. Earlier this year, when I was giving support from the FDI World Dental Federation, giving feedback on the draft, we asked for removal of the word infectious, so that it includes reducing the burden of all disease, so that we can therefore reduce the need for antimicrobials. And this brings into play reducing the burden of cancer, because people with cancer and other non-communicable diseases need effective antimicrobials. And if we can reduce the burden of those diseases, then we can reduce the need for antimicrobials. Within oral healthcare, antibiotics are not usually necessary. More than 80% have been found to be unnecessary in many countries, including the UK and the US. Universal access to oral healthcare to prevent and to treat oral and dental infections is absolutely vital, so that we can use antibiotics only when they're strictly necessary. Thank you very much.
And thank you very much to Wendy for a very sharp and powerful overview of the relationship between AMR and NCDs. Very strong message in relation to the number of the extent of diseases which are preventable, and also where antibiotics are not required. Before we move on, I'm going to ask Colleen, Belinda, Darija, Alison as well, in terms of what Wendy has shared with us there. Any messages from Wendy that particularly resonated with any of you? Please do jump in, any of our speakers.
Yeah, thanks, Howard. Thank you. For those online, I'm Belinda Henderson, so I'm the Chief Nurse for Infection Prevention and Control in Queensland, Australia. I think what resonated with me, Howard, is that real strong message around clear intervention. So early intervention to clear an infection leads to a reduction in the use of antimicrobials. And I think that's the really clear thing, isn't it? We want early intervention and seeking support early for our communities out there, so they're not then relying on very bad infections as Wendy just described. Thank you.
Thanks very much, Belinda. And I saw thumbs up in the chat as well. Colleen, Darija, anything that you would want to add, or Alison, in relation to what Wendy has said?
Thank you so much, Howard. And maybe a very quick one from my side is something I'm going to touch on as well. So reducing the burden of all diseases is key to AMR, and I would say the other way around is also true. So this is a really great opportunity for all of us to talk about NCDs and AMR in one conversation. This is very new. Up until the high-level meeting this past year, I think we didn't even really strongly bring in the link at the national or global level. And I think this is definitely very encouraging to start this conversation, even though it is a few years late, I will say. Thank you.
And I think you make an incredibly important point about how we eliminate AMR from the list of major global health threats. Is back to, you know, a message from all health professionals from the beginnings of time about the importance of prevention. Thanks so much, Colleen. I'm going to come back to you in a moment, Colleen, but whether if Alison or Darija want to jump in.
I just want to say that for me, as a pharmacist representing hospital and community pharmacy and International Pharmaceutical Federation, for me, is striking that more than 80% of antimicrobials for prevention in dental prevention is actually unnecessary. Because you're always thinking about the community, like hospitals, but you never thought about the dental. And I think this is what is the most striking to me, and is definitely something that can be done on that matter.
I was struck by exactly the same, Darija, in terms of just how high a percentage it was. But I guess I don't think my family are probably that unusual, and the rest of you may also have families who, if they do get a tooth infection, you know, their immediate rush and reaction is to try and get some antibiotics. So big number, and again, a real, I think, important public health advice information there as well. Let's move on now then to our second speaker. I think our speaker who wins the prize for getting up earliest in the morning to join this webinar. I think it's just coming up to about 6 o'clock, for Dr. Colleen Mattar, who is the Associate Professor of Medicine, Director of Global Health Education and Partnerships at the School of Medicine, Washington University, an Associate Program Director for Infectious Diseases, and a whole pile of other things as well. But I think important also to mention, Colleen, that you've worked with the World Health Organization as a specialist advisor on AMR, workforce infection prevention and control. And we know you very well in Geneva from when you're here and you're intervening, you're bringing your expertise. So it's great to have you with us. And you're going to talk about linking antibiotic stewardship to NCD care pathways. Over to you, Colleen.
Thank you so much, Howard, and hello, everyone. It's definitely great to be part of this interprofessional webinar, and also having had the chance to be part of many WHPA events and working together with Howard and colleagues on all of the issues that Howard just mentioned. I think the interprofessional aspect of our collaborative and of our group is really a model that is cited in multiple places, including at WHO. And I hope that that will inspire many of you to come together with health professionals locally so that we can make progress on actually about every single disease, but more importantly on prevention, as Howard alluded to. I am going to keep my remarks short. Hopefully the morning brain will comply with this wish as well. So I think building on what Wendy was talking about, AMR remains a silo, and whether we like it or not, it absolutely is. And I think it's something that is important to mention, that it is a cross-cutting issue, and I'm not going to talk about One Health. Absolutely it is, but I think that's a very kind of complex conversation to be had, and we're all human health professionals over here. So I'm just going to touch about how it is a cross-cutting issue in the human health, and how can we link this to outcomes for non-communicable diseases specifically at the national level. So I think one thing that I think will be very clear to everybody here who practices in the clinical space or on the prevention space, I think AMR programs are not suited for the vertical structures that have traditionally been the model in global health. So for example, if we're talking about HIV, malaria, TB, etc., those are vertical programs that have worked somewhat and made tremendous progress over the last several decades. AMR is an issue that includes resistance in the fields of TB, HIV, malaria, etc., but also is much broader towards the invisible part of it, of bacteria that affects every other diseases care. I think it's really something that we've linked in the big messaging to two big things: cancer care and surgeries. But I do think, and I want to point that out just to remind you, that it's not just cancer care. It is also every aspect of chronic diseases. So if we're thinking about the epidemiologic transition that has happened in about every country or many countries around the world, so just thinking about the last, since the 1990s until the decade that we are in now, many countries have transitioned from having the highest causes of mortality being mostly infectious diseases now to the top 10 causes or the top 5 causes, really including non-communicable diseases, strokes, cardiovascular disease, diabetes, etc., etc. So really we're seeing the traditional HIV, TB, and malaria really kind of dropping down. But the one thing to remember is drug-resistant infections, unfortunately, are not counted when we're talking about the top causes of mortality. If you look at the global burden of disease study, or particularly global burden of AMR study that came out of the Institute for Health Metrics and Evaluation at the University of Washington, which is the holy grail, as you know, of global health epidemiology, AMR is directly responsible for over 4 million deaths around the world just 5 or 6 years ago in 2019. So if we can keep that in mind, I think it's important, because when we say heart disease is responsible of X million of death, what is AMR responsible for? So in terms of the other diseases that are very simple, very widespread, simple is not the right word, very widespread and very prevalent. Thinking about diabetes. Diabetes in and by itself is an immunosuppressive condition. So remember, uncontrolled diabetes decreases the ability of the body to fight infections. And what happens? Repeated needs for courses of antibiotics, repeated infections, increasingly drug resistant. Chronic obstructive pulmonary disease, or COPD, is another great example of a disease that we try to treat in a way to decrease inflammation. Lungs are not exactly where they should be. They keep getting worse. We get repeated drug-resistant infections. So how do we link all of these diseases that, as Wendy alluded to, require antibiotic therapy for recurrent infections when they are not controlled? So how about proposing a wish, but not really just a wish, but also something that we can concretely ask for and that we can concretely wish for? And I know many of you in the audience are leaders at the national, regional, and local level. What if we include antimicrobial resistance in national NCD registries? So right now there's a lot of excitement in counting the number of diabetics, in counting the number of people with XYZ cancer, and then looking at their outcomes. So how about we include antimicrobial resistance, antibiotic use, but also stewardship interventions as a key quality metric in these national NCD registries? What would that really do? If we are thinking that what the goal is to improve access to care, improve access to quality care, let's think for a second. If we are including stewardship as a quality metric, we can also include the traditional quality metrics of diabetes control, of cancer prevention, etc., etc. I also think that there's an additional point that's really important if we are thinking about the linkage between NCDs and AMR and inclusion in the national registry. We push very heavily in all of the health professions educations to talk about the latest and greatest in diabetes care, the latest and greatest in lung disease care. And I would just like you to think about the great medications and advances that we have, but there are also innovations from the private sector, which are also phenomenal. But these are important. The prevention is essential. And then downstream effect of that, the education of practitioners from every health profession on AMR is is and needs to be included in every aspect of NCD care. And I'm going to wrap up here very shortly. Participatory learning, this is something that I bring up in every discussion around health workforce. Top-down approaches on workforce that like to come from governments, from sometimes the WHO. I push back and say us health professionals have the agency. We know what our problems are at the front line. In participatory learning, be it an AMR and NCD care, working together, bringing ideas together is absolutely crucial and essential. And finally, I would like us to remember that health equity issues really touch AMR, NCDs, etc. So thinking about poverty, gender, access to care, access to medications, those increase the severity of any disease, including non-communicable diseases, leading to further and further drug-resistant infections with poor access to antibiotics. So I think this should always stay at the forefront of our mind when we are thinking together about the linkage between NCDs and AMR care. I think I will stop here and definitely looking forward to the conversation. Thank you.
Colleen, thank you so much for such a in just a short period of time, such a rich and thought-provoking set of comments and observations. And you're absolutely right. We're very used to talking about NCDs as being, accountable for 70-75% of deaths, but not recognizing that AMR isn't included. So you threw out a proposal there in terms of including AMR in NCD registries in countries. Alison, Darija, Belinda, thoughts and reactions on that? I always like if we get a policy proposal that comes out of these discussions as to whether to test the water to see whether there's a cross-health professional support for that.
I think, from my side, one of the things that stood out to me, well, there's two things actually. One is on the last point, is that it's more than just a medication thing. It requires looking at all the determinants of health as well, and addressing those health inequities that exist. And I think that tags on to the previous speaker as well. And then also that it needs to be kind of a multi-pronged approach with multiple different professionals involved in it. As well as different sectors of healthcare and environments. So like food and water and sanitation, etc.
Thanks so much, Alison. I think I can see Belinda, who was nodding her head as well. But Belinda, Darija, any in terms of thoughts on best practices or policy asks as well? Any thoughts from either of you?
What I really like for her, like as Alison also mentioned, like touching the inequality, and so maybe for the participants here to share their best practices in their limited settings so this could probably help to inspire all the leaders, as Karen really nicely mentioned, that you here that are listening to this webinar are all some kind of leaders in this prevention of non-communicable diseases, and AMR. So if you can share best practices to inspire other people to continue, and then you will, like with a small, like a butterfly effect, you will make a global change. And I think it's really important to inspire all other people, not just act local and globally. It will be transferred to global level. That's I have the message from Colleen.
Yeah, no, absolutely. Me too, Darija. Colleen, you also at the end of your comments talked about the importance of participatory learning. Just so that we're all clear, because I think sometimes people can jump to their own interpretations of what participatory learning is. What do you mean when you say participatory learning?
So I'm just going to give a very quick example of a study that I actually presented last week from somebody who's a few doors down from where I work. He's a big implementation science researcher in the HIV world and was working with colleagues in Zambia. So they were looking at why are people not coming back to a specific set of clinics to get their HIV care. 200 participants, not everybody, the 200 that didn't come, they said they just partly didn't have a great interaction with the health workers who were there. So the team went on this very big, very expensive exercise with human-centered design to try to resolve the issue. They thought that just healthcare workers were just not nice. The reality was that after weeks and weeks of deliberation and finally talking to the health workers themselves, they actually figured out that it was a completely different issue. It was mainly about the access to quality care, the things that those health workers at the front line couldn't really provide. And then they went back to the drawing board to do the specific coaching and improve access intervention. So really, lots of people with the outward gaze towards health workforce, particularly at the front lines, have pretty much set ideas for the solutions that we need. And I think this might resonate with many of you here who work at the front line. The issue is we need participatory learning. We need to learn together. We need to have health professionals as part of the design of the learning and that the needs of the local context being taken forward. So I think this is mainly an easy way to explain and clarify what I meant.
Couldn't be clearer, Colleen. And again, I think, is a concept which sits at the heart of many other approaches that we need to take to other health challenges in terms of patient-centered, genuinely meaningful engagement and collaborations between those with lived experience, those with conditions, and those of us who are providing care. Fascinating that also what you said about patients' perceptions, thinking that health professionals weren't very helpful. How dare they? How dare they? But it's a serious point in terms of, as we know, health professionals working without lack of resources, under pressure, huge demands on them, often without the resources, the equipment to do the job themselves. But that when that translates through as a perception that the problem is with the health worker, with the healthcare professional. So I think there's a huge amount in that issue as well. Let's move on. Thank you, Colleen. Let's move on to Darija, Kuruc, Poje, who joined the board of directors of the European Association of Hospital Pharmacists in June 2021 and was very quickly elected as vice president a year later. She serves as the head of the hospital pharmacy in Koprivnica in Croatia. Has a wealth of other important advisory and expert roles as well. Darija, it's great to have you with us. You're going to talk about workforce challenges in addressing NCDs and AMR in different income settings. Over to you, Darija.
Thank you very much, and it's really nice for being the part of this important webinar. But before I begin with my intervention, I would like to share International Pharmaceutical Federation AMR declaration that was signed in Copenhagen, Denmark at 83rd FIP World Congress of Pharmacy and Pharmaceutical Sciences that was held from 31st of August until 3rd September. Now I'm announcing the video of the AMR declaration signing ceremony with important points raised by distinguished speakers.
According to WHO, AMR is one of the most serious health threats in the modern world. AMR, or antimicrobial resistance, is when bacteria are getting resistance against antibiotics. That means that we as doctors cannot treat infections caused by these bacteria. Worldwide, AMR is causing more than 1 million deaths directly related to infections with resistant bacteria every single year. And between now and 2050, it is projected that more than 39 million people will die from AMR.
We are delighted to be here in Copenhagen to celebrate the 83rd Global Congress of Pharmacy and Pharmaceutical Sciences. And what a great opportunity in Copenhagen, in partnership with wonderful Copenhagen, to address the thorny issue of antimicrobial resistance. The FIP Copenhagen Declaration on Antimicrobial Resistance offers us an opportunity to engage, mobilize, and amplify the voices of our member organizations across the globe, to take this declaration home, for them to implement it in their countries, and for FIP to support them and stand shoulder to shoulder as we fight AMR.
We are signing AMR declaration because that gives a very strong message that we need to work in the area of antimicrobial resistance in future, and our signing the declaration also shows our commitment towards AMR. When we go back home after signing the AMR declaration, one of the first things that we would like to take up through Indian Pharmaceutical Association is the stronger advocacy with the government for regulating the antimicrobial use or enforcing strictly the existing laws around antimicrobials.
WHO is very pleased to work with FIP to reach out to pharmacists to strengthen health system and have a solid response to AMR. And we expect mostly 3 actions. Number 1, securing access to all the antimicrobials that people need. Number 2, improving use along with the AWARE classification so that we prevent antimicrobial resistance. And third, document the use and quantify the use so that we can base policies on the base of data.
With the FIP Copenhagen AMR Declaration, we will mobilize all our countries, all our member organizations, with a strategic plan to take us through to 2030, so that what we do in nations and globally will ensure that AMR will be solved for the generations to come.
Thank you very much, and greetings, Lea, from Rwanda. It's really nice to have pharmacists here, and I will just continue on that note regarding workforce challenges. As you know, I will speak on the behalf of pharmacy because to treat and to prevent non-communicable diseases, I will say NCD, not to break my tongue, and antimicrobial resistance, we need a sufficient, equitably distributed, and well-trained pharmacy workforce. FIP highlights the pharmacists are increasingly recognized as integral members of healthcare teams in the prevention and management of NCDs. Furthermore, we are the ones that are most accessible healthcare professionals in the worldwide, so every patient can come to us and ask us for the advice on NCDs, AMR, and whatever disease or headache they have. Their accessibilities, expertise in pharmacotherapy, and ability to provide personalized counseling enable them to support patients across a wide range of conditions. Addressing NCDs, whose risk factors include poor diet, physical inactivity, tobacco and alcohol use, air pollution, is key to mitigating AMR, as these factors compromise immune response and heighten vulnerability to infections. Beyond dispensing medicines, and mostly of you know us, pharmacists play a vital role in managing minor illnesses, offering lifestyle counseling, and delivering health education. However, according to the FIP Global Situation Report on Pharmacy, the world faces an estimated shortfall of 11 million health workers by 2030. The disparity in pharmacist distribution remains striking. High-income countries average 12 pharmacists per 10,000 people, while low-income countries average only 4, representing a threefold gap. To ensure a sustainable and competent pharmacy workforce, it is crucial to advocate for professions' role within health systems, promote continuous professional development and career advancement, and invest in workforce planning, well-being, and interprofessional integration. On the supply side, pharmacy education capacity remains a major bottleneck. 71% of countries have fewer than 1 pharmacy schools per million people, and annual graduate output varies widely, from fewer than 10 to more than 100 new pharmacists per million population. Regions with highest need, such as Africa, continue to have the fewest schools and graduates, while Europe and the Eastern Mediterranean region have experienced rapid expansion, widening the global gap despite a projected 40% increase in global pharmacist density by 2030, compared with 2016. FIP therefore calls on the Health Ministry funders and education leaders to expand pharmacy education, strengthen incentives for rural practices, and embed pharmacy within national universal health coverage and workforce investment strategy. A well-educated and adequately supported pharmacy workforce is fundamental to improving NCD management and, in turn, combating antimicrobial resistance. But we cannot do it alone. We have to have the support from physicians, nurses, physiotherapists for every healthcare workers, and also from patients as well. Thank you.
Thank you, Darija, and for sharing that great video as well. So many important and key messages. It was lovely to see Catherine Duggan, the wonderful CEO of FIP, in your video as well. Darija, I was struck by so much of what you said about issues to do with shortage of pharmacists, inequality in distribution of pharmacists, but also how important pharmacies are as a point of access to healthcare. So much of that I know resonates with the nursing profession as well. I'm sure with other colleagues. And I wonder what because we don't hear it said very often, but when the way that you presented those issues with the healthcare workforce, they are factors which put us at risk, not just of widening health inequalities and not addressing the threat that AMR is, but arguably as well, some people would say how quickly we may face the next pandemic and issues of other infectious diseases. What are your thoughts, and from FIP, on how we articulate and make that link between health workforce and the threat to global health?
Actually, one step ahead is this FIP's MRI declaration, where it was signed by 82 associations, and as you saw, we had a support from the World Health Organization and a lot of different professions. So we started to work interprofessionally and to gain the momentum, so we can start to tackle this workforce issue that I know in nursing are tremendous. By then working together and building together these forces, I think something will change. As even I was now speaking from a European point of view. European Commission has started finally to go through some steps to have more workforce. But what really troubles me and what really worries me is, as I mentioned, African region. But I think that has to have much bigger and louder voices for pharmacists to have more workforce. So we should be louder and have more events like this one, and go to the policymakers actually go to Africa. And I believe that speakers that will come after me could speak on that behalf much more than me. But I think it's something that should be done, and we have to also raise this issue and talk about it and try to find the ways how to help to gain more workforce. But as we said, we have to have access to quality of care as well, as Colleen mentioned.
Thank you, Darija, and those of you who are listening in as well. Your thoughts or your questions, particularly on some of these health professional workforce issues and challenges that both Darija and Colleen have mentioned. Any observations or comments, please, as well as questions, do put them in the chat for us, and we'll come back to them at the end. Let's move on next to Belinda Henderson. Belinda has over 25 years experience as an infection control practitioner, is a past president of the Australian College of Infection Prevention and Control. She's the chief nurse for infection prevention and control for the Queensland Department of Health, and leads Queensland's IPC unit. Like all of our other speakers, Belinda also has a whole range of other advisory and educational responsibilities and duties as well. And Belinda is going to share with us some thoughts on how infection prevention drives effective AMR action. Belinda, over to you.
Yeah, thanks so much, Howard. I'd like to start by acknowledging the traditional owners on the land, owners of the lands on which we meet. I'm on the beautiful Moreton Bay, so the land of the Quandamookan people in Queensland, Australia, and I'd like to acknowledge elders past and present. I'd like to thank the International College of Council of Nurses for inviting me to be part of this very important conversation. And the discussion so far just leads in really quite nicely to what I'd like to just cover in the next couple of minutes. But AMR is, as we've described, the top 10 global health threat, which will touch each and every one of us at some stage, not just in our professional lives, but in our personal lives. So I think professionally we need to continue to work together in collaboration to influence the strategies and the response to resistance. In my role as a leading subject matter expert in infection prevention control, I've got a responsibility to govern, teach, respond and educate best practice and really first principles for infection prevention and control. AMR and AMS does not solely sit with one professional role, as we've all described, and it's so lovely to be part of this conversation as I've described. We all have a really important part to play. My role is really advocacy at a very high level of governance and government, developing sound policy and the response that supports and reduces the incidence of transmission events of these drug-resistant organisms and certainly other organisms of significance. And I think when we think about infection prevention strategies, it's really around the sound use of standard precautions that we use for all patients, regardless of what we perceive infection status to be, environmental hygiene and cleaning, isolation procedures, and of course, screening of those high-risk patient populations. And then leading into that, of course, is around surveillance and data collection and outbreak response. And really the education makes up all of those basic principles for infection prevention control. And really, these principles were first described by Haley et al. Back in the 1980s as part of the pivotal scenic study, which those people that have anything to do with infectious diseases, infection control would be very familiar with online. But the benefit is with first principles of infection prevention and control is you don't require a fancy hospital or a primary care setting. And really, you don't need anything that's too special. The principles can be applied across all settings, across the health continuum. And so that equality element becomes really, really important. And really, when we think of infection prevention control, it's one important piece of a very large puzzle. As our profession is made up predominantly of nurses, scientists and epidemiologists internationally, we have the opportunity to share our knowledge and experience and to educate our communities that we care for around the simple principle of good prevention and stewardship. So really, you've all heard these terms, I'm sure, but clean hands save lives, cover your cough, don't go out and about if you're unwell, and in particular, avoid contact with our most vulnerable, that being those babies, patients with cancer, those with weakened immune systems, including patients with chronic diseases. We know that skin integrity is really, really important. And really, I guess the message is around remembering that not all coughs and colds and illnesses and troubles need antibiotics. But if you are prescribed them, it's important that you do actually take them and take the full course. I think as clinicians, we have a duty of care and responsibility to share our surveillance data, the trends and the resistance patterns. And in my 30 years of being an infection prevention and control professional, it's changed. What we're dealing with has changed. And in various settings, the organisms or the epidemiology that's significant to us is different. And what we need to do is ensure that we share those resistance patterns and the outbreak details with others within our healthcare circles. And that's not just the doctors and the nurses. It's looking at the pharmacists, the infectious diseases physicians, clinical staff, including our wider allied health team, because anyone who has contact with patients and is delivering any type of care has an accountability and responsibility to minimise the risk. Microbiologists are very, very important, of course, and as are our clinical informatics team, so the people that look at all of our data and pull it all together on a local level and a national level and, of course, internationally. We need to make sure that our data is okay because we need to be using consistent and contemporary surveillance definitions. and that our data is valid, because really these data points need to be comparable across systems and across environments, because otherwise we're not comparing like with like. And I think my end point to think about would be around the opportunity to provide direction and guidance and support the human and the One Health approach via the broader international and interprofessional community. And I think that's really important, because what we're all here for is to promote quality and safe and consistent care to our communities. And really that flows on quite nicely to being an effective response to resistant pathogens. And of course, we need to make sure we engage our consumers. Our patients need to be at the table and part of the conversation, because otherwise, as Darija described, it's a thorny issue. And we're not necessarily doing it well internationally, but we're all sitting around the table and having these conversations, which I think are key and important. Thanks so much, Howard.
Excellent, Belinda. Again, so many just fantastic points that you made. I was also reminded as you were speaking about, first principles regardless of settings, but how often we have conversations with, in our case, nurses from around the world, where somebody actually puts their hand up and says, but do you know we don't have access to reliable water and sanitation? I think the estimate is about 1 in 4 healthcare facilities around the world do not have access to reliable water or any water at all. Your first principles points, so important. And I wanted to cheeky-ish question, but I wanted to ask you as well your thoughts as to whether the new graduates you see within nursing, and this I'd ask this to the others as well for the other professions, whether they are well prepared with those first principles when they come out of education, or whether there is more that we need to be thinking about in terms of health professional education. I'd be interested in others' thoughts on that as well. I thought is that very important point about data sharing that you made. You've made the point, but hearing, but if Darija or Alison or Colleen had thoughts on how we're doing with data sharing, that would be helpful. But first, back to you, Belinda.
Yeah, thanks, Howard. I think your point's a really good one, isn't it? There's so much information for our new generation of healthcare providers to learn. Infection prevention and control is one small element. And for me, it's one of the most important elements, because it flows on to everything that we deliver, regardless of what type of patient you're looking after, what type of setting you're in. If we don't do the general hygiene stuff well, and I take your point around water and poor environments and sanitation and those things, but there are other things that we can put into place to minimise the risk. So it's that first principles is really important. I think there's some work that we can do to improve the education in some settings. And really it's the reminders, because as a professional working in hospitals and walking through hospitals all the time, it's not necessarily the new graduates that aren't doing what they need to be doing. It's often our esteemed colleagues and physicians and very senior staff around the place. But really what I think we need to do is advocate for the voice. So it doesn't matter what level of staff you are, it's okay to challenge each other, and you can challenge each other in a really kind, professional manner. Hey, Belinda, I just wanted to check that you've washed your hands. You've got your beautiful long nails on because you're getting married in a few weeks' time. That's wonderful and congratulations, but you can't effectively clean your hands if you've got lots of extra things all over them. Those types of conversations, I think, is what we need to do better in our training and teaching of our new graduates right across all of the health continuum, in my view.
Belinda, and thank you so much for tackling head on the question as well. Colleen, Darija, Alison, your thoughts on both the education point and the data sharing point?
I very quickly, I think I 100% agree with Belinda, and I think we've gotten a little bit better on the pre-service or undergraduate education, and it is the continuous professional education that we really need to focus on. Definitely from the physician perspective, the very clear data for prevention of infections, surgical site infections, catheter-associated bloodstream infections. We have data, we have better data, and how do we take that knowledge to the colleagues on who don't have this at the back of their mind as they're trying to do their best for the patient as well, which is exactly what I will be doing next week with our neurosurgeons in the hospital. Please wish me luck that I come back in one piece. But this is I think 100% something that's super important. On the data sharing side, I think we're really we keep talking at the global level that we need data sharing, then we in every aspect, and then we get roadblocks from people who put up the privacy issue, but who also put up, I don't want to share data, or that should be up to the local or regional, etc. I think we can make headway with national data sharing, at least publicly available data. Of course, in the settings where resources would allow, because as you rightfully so mentioned, Howard, if you don't have access to wash in your facility, it feels a little bit far-fetched to ask for robust kind of national data, if that makes sense.
Thanks, Colleen. It does indeed. It does indeed.
If I may add just a short,
do.
what I really, really like, what a lot of physicians and nurses and my colleagues told me, and also physiotherapists, they said, lead by example, be a good example. You cannot have a long nails and then you talk to your colleague. You cannot, because so be what you preach for. So I think it's really, really important, because younger people that comes from that graduate, they learn the infection prevention and control, and then they see you do not care about it, and then they will not care. So I think it's really important that we have to be responsible for us, but also for the people that are coming, younger or older one. So even if they are our colleagues. So I think it's a really important message that I would like to convey with you. Thank you.
Yes. And I think the most important thing too is that people don't come to their workplace to cause harm. We come and we do the best job that we can with the situation that's in front of us. And I was recently in Mongolia assisting with a large-scale outbreak of measles infection, and the wonderful work that can be delivered when you come back to first principles, even if your physical environment is not necessarily suitable, is just hats off to all of these incredible people all around the globe doing wonderful work. And we do need to remember, people don't come to work to cause harm, but sometimes they just need a little bit of a poke in the right direction to ensure that they are being compliant and doing what they need to do to reduce the incidence of resistance transmitting around our patient populations. Thanks so much, guys.
Thanks, Darija. Belinda, everybody's heads nodding along, and I can see the reaction in the chat box as well to those comments. Alison, certainly by no means least, but the last of our speakers, thank you for your patience. Alison is qualified as a physiotherapist from the University of Cape Town, South Africa, in 2007, and then got her PhD in 2017 and her MPhil in Health Professions Education in 2024 from Stellenbosch University. She's a full-time lecturer in the Department of Physiotherapy at the university, and like everybody else is advising on a whole range of committees and groups, both at a national and international level. Alison, it's great to have you with us, and you're going to give us some thoughts on physiotherapy's role in reducing fragmented NCD care that drives repeated antibiotic use. Over to you, Alison.
Yes, cool. Thank you very much. And yeah, thanks very much for the opportunity to share from my professional kind of point of view. So yeah, I think if we're talking about NCDs, and I think it's already come up, I think Colleen mentioned it around, the burden of disease and the high burden of chronic respiratory disease globally, as well as in low middle income countries. And conditions like diabetes, which I think, recurrent infections delay healing, that leads to antimicrobial use. And at the end of the day, where I come in rehabilitation is, when amputations are needing to be done. So I thought I'd just touch on those two areas, and just our role in the care there around preventing decompensations, which then lead to hospital admissions and antibiotic exposure. And then also, how do we as physiotherapists and rehab professionals help? How can we help in fragmented care? So from a chronic respiratory disease perspective, and here I'm thinking kind of largely around your COPDs in low middle income countries where there's high burden of tuberculosis, we are starting to recognize the impact of post-TB lung disease. And often these people are ones that have exacerbations, they're poorly managed, end up in hospital needing antibiotics, and potentially perpetuating the AMR. And there's quite good evidence that physiotherapists involved and pulmonary rehabilitation, of which physios are one of the core people involved in that, how that can prevent exacerbations as well as hospital admissions, with 2 Cochrane reviews published, one in 2015 by McCarthy and colleagues, and one in 2016 by Puan and colleagues, where they were able to show a significant reduction in hospital admissions of people who've gone through a pulmonary rehab program, and showed mortality benefit as well. And there it's really around helping and empowering people through exercise and education interventions to promote health enhancing behavior that leads to then sustainable change. And I think particularly I come from a resource limited setting, and I think particularly in those areas it becomes quite important where we are able to empower and give agency to the patients themselves to help in terms of their self-management, particularly in areas where health literacy is low, and where they might not be able to access the direct and immediate care that might be available elsewhere. So where you've got 3 pulmonologists for a population of 3 million people, accessing that care is almost impossible. And so often physiotherapists are the first kind of line of contact, and usually the most consistent line of contact, where we travel a journey with people. And so we are very well positioned to help there with health promotion and disease prevention. Just to highlight again, I think the empowering and giving agency to the individuals with the NCDs, I think is really important, especially where access to healthcare is really difficult, and where those inequities, which we've spoken about before, exist. The same thing with diabetes and diabetic care. So where, particularly again in low resource settings, where you've got one doctor who needs to see in excess of 60 patients a day, and these are not simple patients, they are patients with multimorbidity. Here again, it's difficult there for the right education. And when I talk to kind of limited doctors, it goes to nursing the same. And so that education component and empowering component that happens or that should happen is limited. And so I think again, physiotherapists, they are very well positioned to carry some of that care when we do see patients. And again, here it's around health promotion and disease prevention, and re-enabling people to live productive lives and reducing infection with it. And then, like I've mentioned before, I think with the improving the fragmented, our role in improving the fragmented care and kind of looking at more at interprofessional care, I think physiotherapists, and I think it's the same across the world. We do have different scopes of practice, but I think we are some of the ones that are quite well linked into the health team. And like I say, we are often the ones that travel quite a long road with patients and develop that long-term relationship. And so we are the ones that, in my experience, are easily able to pick up things that maybe need to be escalated into care. So it's around helping improve access to care. But we're also the ones that are at community level able to deliver the care and partner with community health workers and different communities. So I think my experience is that we are sometimes the plug-in to the health system for patients where access is difficult. And we do have a big role to play in terms of helping improve patients' agency and people's agency around their own health, and empowering them in a system that often is disempowering to start, standing up for their health and well-being. I think if I can end there, short and sweet.
That was great, Alison. It's I think you pulled together a number of themes that had come up in the discussion, and I was quite struck because I think it had come through in the comments from pharmacy, from nursing, from the dentist as well. Just the being so close to patients. I think you described it as traveling the journey with them, and what opportunities that closeness, accessibility, continuity then provides for health education, for empowerment, for addressing health literacy issues as well. From you, Alison, but also from the others, I'd be really interested. What have you seen? What do you see, and what have you seen as to sort of the best practices in terms of multi-professional team working that work to address all the risks we know of fragmentation and systems not talking to each other and people falling between the cracks and having to repeat their stories and all of that stuff that we know irritates patients and their families hugely. From you, Alison, but also from everybody else as well. Again, your top tips on really effective team working that can overcome some of those challenges and barriers.
Yeah, so I think from my experience, and I'll use it in the context of chronic respiratory disease, and I think, pulmonary rehabilitation by design is an interprofessional design. So it helps if there are those frameworks and guidelines from, for example, World Health Organization and big bodies that provide that guidance. But from my side, I think it is where there are healthcare professionals, and other team members that recognize that we don't just operate in our silos, and that it is a shared thing, and that really opens the doors for the interprofessional communication, as well as improving the health journey of the patients. I've had cases where you have someone who's willing to hear your voice as a physiotherapist and maybe not a specialist physician. And at the end of the day, it's about the patient and the patient's improving the patient's care and outcomes. So I think it is around having people who see that they can't just operate in their silos and have this bigger picture, towards health. And I think, that's some of the teams that I work in, at least.
Thanks, Alison. The rest of you as well, your thoughts on that question, and also the other issue which has come up in the Q&A, which we probably haven't specifically addressed, is what the role of technology is. To what extent this effective team working and addressing fragmentation, technology, is it the saviour or is it still a hindrance and getting in the way? Belinda, Darija,
I think, Howard,
Colleen?
I'll go first, guys. I think in terms of just picking up on what Alison was talking about, I really like the empowering health enhancing behaviour. I really like that. My son's a physiotherapist, so I'm told these types of language all of the time. But I think it's around holistic care, isn't it? It's not just looking at one part of the patient, it's looking at the whole patient, looking at the environment in which they come from, their community supports and all of those types of things. And I think that we need to do that better across the whole continuum, because otherwise you do miss the stories. And as you described, the patient's got to repeat themselves 4 or 5 times to a number of different professionals, depending on, what their role in the care is. So I think that's important. In terms of hindrance or help with technology, I think that the equity is going to be challenging with technology across the globe. But I think that it's a big part to play. There's opportunities around, linking data sets, so pathology data to show what organisms are resistant to which particular antimicrobials, and then my pharmacy colleagues, I'm sure, will say, you know, that's so important. We want to make sure that we've got the right antimicrobials matching the organism. And then, you know, our ID and medical colleagues will be saying, well, it's really important. We need to, you know, broad spectrum versus narrow spectrum. What does that look like? Let's reduce the impact on then creating more resistance. And then, of course, we've got the concepts around jumping genes. So technology has a big part to play. There's lots of research internationally happening in lots of different countries, low and middle income countries as well, around trying to link that data. So then we've got better, robust data that we can drive, because there's no use collecting data if you don't use it for action. That's the key public health message. And we don't want our staff collecting all this data and not doing anything with it. So it needs to be driving our change and driving those conversations. So it is a hindrance, I think, in a lot of situations, because people just don't have access to good quality data. But I think, as Colleen, you described before, the challenge also is getting consistent data definitions. We can't get them nationally in some countries, let alone internationally. So we've got lots of work to do in this space, but I think it's a really important piece and an exciting piece of work for us moving forward. Thank you.
Thanks, Belinda. Colleen, Darija, on this, on the data technology empowerment piece, your thoughts?
Yeah, so I maybe want to build a little bit on what Belinda just mentioned. You hit the nail on the head, particularly on the machine learning side. The quality of the data you get is what you feed into. And for that, I think as everybody, or I hope many know, that the structures that we have on the international front, but also on the national front, unfortunately for AMR specifically, are very skewed. So hopefully there's no one from WHO on this call, but GLASS is definitely an effort that got us from, which is the surveillance system that countries are feeding into for resistant infections. It's the best that we have, but it really is far from a place where we can actually utilize this to a context-specific frontline clinical guidance. And the other worry that I have right now is the involvement of the private sector and the private entities in data mining, particularly in low and middle income countries, to produce really very heavily unregulated apps, AI structures, etc. And this is where we as health professionals really need to be at the forefront of the development of the technology, but also of the regulation and pushing for further regulation. There is so much potential for data, for digital tools and AI to be extremely supportive of all of us here in the clinical setting, but really we need to be the sounding board for everybody, including the regulators, who may, or actually not only may, who usually don't really have a clear idea of what they're talking about when they're working with the private sector, particularly on the data front.
We're Colleen, thank you so much. We are drawing to the end of our time together, colleagues. So I am gonna ask each of our panelists for their final 30-second maximum takeaway from our discussion, which has been very rich. So it's not easy to pull out your top takeaway message, but let's have a go, see how we do. Darija, I will come to you first.
Okay, I will just continue to the digital tools and then conclude. So what I really like what Colleen mentioned, that without human, digital technology and artificial intelligence is useless. And as Belinda mentioned, and Alison as well, we have to use it wisely, and because it's helpful, we are here. You see people from Africa, from Ukraine, from USA, from Australia. It's because of the digital technology. So this is one thing that we have to appreciate. On the other hand, we have to be really careful. We have to be really critical. How are we using? And definitely what Colleen mentioned, we have to feed the system with the good information, and we have to be critical and self-critical as well. So this is my first. And the second thing is, I really like that you resonated with you to lead by example, and then the rest will come. So this is for me. From me.
Brilliant. Thank you, Darija. Alison.
Yeah, so I think my take home is that it's no small thing, and it requires an interprofessional, multi-pronged approach to address, AMR and some of the things that sort of, we need a bottom-up approach as well as, as much as we need a top-down approach. So we really need to tackle it from all sides. Yeah.
Excellent, thank you, and Belinda.
I think, in short, we all have a really important part to play, and the fact that we're sitting around the table, we're already one step in the right direction.
Great. Colleen.
Also on that front, I think coming together as one voice for the health professions is going to take us much further, and I hope that we can continue the engagement, particularly together on the AMR front.
Listen, that's great, and I wasn't cheating. I'd written down myself that we'd started off talking about One Health needs cross-sector, cross-border, cross-professional working, but like all of you, I think we got this. And when we come together and we work together in a multi-professional, interprofessional capacity, I think that we, as I say, we've got this, and we can overcome these challenges, and together bring not just the relationships with patients and the trust and the confidence, but bring the solutions that work as well. Your panel, I think, have been fabulous. Wendy, Colleen, Belinda, Darija, Alison, you can show your virtual appreciations with the clapping with the clapping hands, and I thank all of you as well. To FIP, to Albina, for all of your support for making this happen, and the technology that has worked. Joanna, our manager from the World Health Professions Alliance, who put all of this together and coordinated us. Thank you to you. Thank you to everyone, more than 360 of you who have stayed with us throughout, which says something as well. So thank you. And watch out for the recording and further information on all of our individual websites and also on the WHPA website. Take care, enjoy the rest of your day, and we'll see you all again in the not too distant future. Bye-bye, everyone.